Hello, everyone. I'm Kathy Sikkema, Chair of SMS. I'm pleased to see everyone here. We're actually going to start today's Food for Thought in a slightly different way in recognition of Dr. Carol Caton. And I'm going to turn that over to the Marita Merman, who many of you know, who became Professor Emeritus in July, but she's doing happy in retirement, but really wanted to come back for this lecture. So we're thrilled to have her. Here you go.
Thank you so much, Kathy. So good afternoon. As Kathy just said, I'm Marita Merman, Professor Emerita in Socio-Medical Sciences. Today's Food for Thought, Critical Reflections on the Social Sciences and Public Health Seminar is being supported by a gift from the estate of the late Dr. Carol L. M. Caton. Dr. Caton completed her bachelor's degree at Columbia University and her master's and her doctoral degrees at Yale University. Dr. Caton held faculty appointments at Yale University School of Medicine, SUNY Downstate Medical School, and the College of Physicians and Surgeons at Columbia University. Prior to her passing, Dr. Caton was professor of Socio-Medical Sciences in Psychiatry and Public Health. Dr. Caton served as principal investigator and director of the Columbia Center for Homelessness Prevention Studies, a mental health services research center focused on the development of interventions to prevent chronic homelessness. Dr. Caton was the author of 3 books, including The Open Door, Homelessness and Severe Mental Illness in the Era of Community Treatment, published by Oxford Press in 2017. Dr. Caton published extensively on schizophrenia, homelessness, and dual disorders. She participated in the development of Uniting for Solutions Beyond Shelter, the New York City plan to end chronic homelessness. Dr. Caton presented her work at numerous national and international forums, including the United Nations. And she served on the research advisory boards of the New York City Department of Homeless Services and the National Alliance to End Homelessness. Within the Department of Socio-Medical Sciences, Dr. Caton was an admired friend and colleague, and a master's thesis sponsor to more than 9 SMS master's students between 2018 and 2021. In Carol's words, I quote, "I have been an observer of the events that have given rise to homelessness and a participant in the quest for solutions that would bring greater stability to the lives of people with severe mental illness. Over the past 35 years, I have worked among clinicians, researchers, and advocates who have been inspired by the challenges imposed by homelessness to devise innovative service and policy interventions and creative housing initiatives." Carol went on to say, "This collective body of work has advanced the evidence base in the care and treatment of the homeless mentally ill, paving the way for continued advances toward ending this American tragedy," unquote. I will now turn the podium over to Dr. Kathleen Sikkema, Chair of the Department of Socio-Medical Sciences, to introduce today's speaker.
Thank you, Marita, for saying such wonderful words about Carol Caton. I would like to note that Carol's daughter is here today, Dr. Lisa Schwartz. Do you want to stand up or not so much so? So that you know how much we appreciate your mother and everything she did with us and what a close colleague and friend she was. So we're very thrilled that you can be here, and hopefully you can sense how much we value her and her work. In that light, it's just, I think, remarkable that we are able to have Kelly Knight be our speaker for today. I'm not sure we could have had a better speaker to honor your mother and to continue our focus of interest in the area in SMS. So let me just say a few words about Dr. Knight and then let her work do the talking about her mostly, because we're all very excited to hear from her. She's a medical anthropologist who received her PhD from the Joint Doctoral Program in Medical Anthropology at a program some of you may know, which is it's a combined UCSF and University of California, San Francisco, Berkeley program. In many ways, she really represents our PhD program as well in terms of how she approaches issues of public health. She has for 25 years conducted, I think about 25 years, conducted qualitative research and harm reduction service provision for people who use drugs and experience homelessness. She's very well known for a book called Addicted, Pregnant, and Poor, highly regarded, very well reviewed by our esteemed colleague, Kim Hopper, who cannot be here today because he's teaching in the prisons, Kelly. And I think there may be some students from his courses here. So that, I think that work and the work she's doing to date will be reflected in her talk, where most of her work centers on the experience of poverty and addiction in clinical and community settings, homelessness and health disparities, and health conditions that are produced or exacerbated by structural violence. She's currently funded on a PI on two and NIDA research grants that are ethnographic studies in these areas. I won't say too much more about that, assuming that you'll see that in her work. So she's, if I began to list all the various roles she has, for example, she's the, I got to get this right here, the Director of Qualitative Research for the UCSF Housing and Homelessness Initiative, co-director for UCSF Population Health and Health Equity, playing very significant roles in diversity, equity, and inclusion at UCSF, as well as very much work on the opioid crisis, and is very active in the National Academy of Medicine groups in of that nature, for example. So I won't continue with those details, but hopefully you get a feel for how honored we are to have her here. And then go ahead and proceed.
Oh, that would be great. I prefer not to. Can you hear me okay? Oh,
So she doesn't have to hold it.
great. Yeah, that would be wonderful. Well, thank you so much. I'm very honored to be here. And I want to just personally thank Dr. Lisa Schwartz to be here to give this talk in honor of Dr. Caton's significant lifelong dedication to trying to understand and remedy as she put it, the tragedy of homelessness in the United States. I'd also like to thank Dr. Sikima, as well as Yasmin Davis and Michelle Rivera Lopez for helping to set up this visit for me. Very, very honored to be here. I want to start by just positioning myself a little bit. Kathy gave me a wonderful introduction. I have been doing 25 years of engagement with people who use drugs as a health researcher at UCSF since 1995. But also as a co-founder and coordinator for what was called then the Women's Needle Exchange in the early 90s, 98. So this was the first exchange that focused on women and trans women in the sex industry that opened up in the Mission District and was opened up by researchers, activists, and clinicians at the time. I also have served as an outreach worker in the SRO hotels, and I'll talk a little bit more about how that's informed my work later, and continue to be a volunteer. So really had a dual role as a harm reduction service provider and a researcher throughout my career. And what's important about that to me is drawing on some of the principles from harm reduction in how they sort of inform my approach to research and my work. And I'm just going to share 3 of them today that I hope will help shape and form what I'm going to say. First is that all the successful interventions that have helped keep people who use drugs to stay alive have been grassroots, initially illegal, community-based, and user-led interventions. So it's really incumbent upon me as a researcher as I think about what interventions, what structural interventions have worked to help people who use drugs to recognize where they've come from and how to support and elevate the communities and work with them in collaboration. Also, nothing about us without us. This is, of course, borrowed from the disability justice movement in the United States that really talks about the ways in which we need to collaborate, particularly as research is steeped in colonialist, imperialist, and white supremacist ideology, and really rethink our research methods in light of that. And finally, dehumanization and stigma are real and omnipresent. So the recognition of the ways in which our work is informed by the fact that most people's views toward people who use drugs are openly or subtly anti-Black, anti-poor, anti-trans, anti-sex worker, and anti-homeless. The othering is continual, intersectional, and often unchecked. in public and political discourse. And it's precisely that public and political discourse that's been an object of my study and intervention for several years. This is my community of accountability, or some members of them. It's really important for me to make visible and be part of this community in San Francisco as they keep me accountable as a researcher to the research program that I've tried to help create. So what is that program? So first, it's applying the theory of methods from medical anthropology to produce knowledge and to decrease structural stigma for people who use drugs and experience homelessness. And secondly, I consider my research program to mentor and train a workforce to conduct community engaged, NIH fundable, policy relevant health research. And this doesn't happen for me without humility, deep humility intellectually about what I know and what I don't know, about my own positionality in this work, and structural humility about what I can know and understand about the structures at work, and in collaboration. And I hope to demonstrate some of that today as I share my work with you. Borrowing from Laura Nader, who's a legal anthropologist of fame from UC, from Cal, I tried in my research to look at things along a vertical slice. So I look at personal behaviors, how people use drugs, for example, their mental health diagnosis they might have, their experiences of care and illness in relationship to social institutions, living arrangements, negotiation of basic needs, their family, their work, their kinship networks on the meso level, and then all the way up to social policies and institutions of governance and rights at the macro level. How do these intersect along the vertical slice is a research question that I've asked over and over again, and I'm going to share in detail about that in a minute. What methods do I use? So medical anthropologists use a range of methods. These are some that I'm going to talk about today. Participant observation, spending time with people in their everyday lives through what matters to them, and sort of being a traveler along their lives in the everyday way. Qualitative interviews, which most folks in public health are pretty familiar with, usually semi-structured around a research question, often taped and transcribed and coded. Key stakeholder and expert interviews. This is a key piece of my work, particularly in my NIH funding, is to follow the money and make sure that when I'm asking critical questions about the comorbidity of mental health and substance use as it relates to housing insecurity, that I'm talking to policymakers, studying policy documents and understanding the shape and form with which governance and rights are being created in this space, as well as talking to people who are most affected by those policies on the ground and all the people in between, the middle actors, whether they're bureaucrats, clinicians, etc. I do clinical observation, which is spending time in clinics, observing visits and seeing how providers and patients interact with each other. Photoethnography, I'll share a little bit of that today. Policy analysis, I already mentioned. Media and marketing analysis is the ways in which this public discourse around substance use gets created and the people who use drugs. So looking at mediated images and whether they're billboards or newspaper articles, or tracking the ways in which people who use drugs, who have opioid use disorder, who overdose from opioids, are portrayed in the media. Analysis of social media and websites also plays a role in my work. So for example, I've traced websites designed to manage middle-class pregnancies in relationship to messages that are given to very low-income women who have ongoing drug use during pregnancy, and historical archive research. So for today, I'd like to talk about, sort of split this talk up into two parts. They're related, but slightly distinct. The first is about vital politics. And that's the ways in which my work has theorized the intersection of substance use, homelessness, and health. And the second is about chemical politics, specifically the chemical politics of the US opioid overdose crisis. I hope to review a body of work discussing some of the theoretical and methodological contributions that myself and my collaborators have tried to make. And then also, I hope to demonstrate some impact, the ways in which that work has spread beyond medical anthropology or beyond the academy to create generative products in community and clinical spaces. So, vital politics. First, I want to talk a little bit about the relevance of multiple temporalities on research with people who use drugs. And second, I want to introduce you to a concept and a social actor in the space of the political economy of mental health diagnosis and housing that I call the neurocrat. So this is sort of a backdrop slide, but it's a little hectic, and it's hectic on purpose to try and show sort of the fact that I've been engaged in multi-methodological research my whole career. And That research, when I think about the study of women identified people's health, drug use, and sociostructural marginalization, it's never just one study. That's what I say to my master's students in global health and to the medical students. It's always multiple engagements over time, discrete studies that somehow form a body of work and a conversation with multiple interlocutors and collaborators. So some of that work that was ongoing while I was finishing my book project, which I'm going to talk about in a minute, was several NIH studies that were focused on gender amongst HIV positive homeless populations. So comparing men identified people with women identified people. Shelter, healthcare, and drug use was also a follow-up study that focused on violence and victimization, specifically for women identified HIV positive people experiencing homelessness. Looking at environment at risk, what creates risk in environments, policing, arrest, cash entitlements, and sociostructural barriers. These are all factors that formed a backdrop as I studied both the science, the research science, the production of knowledge in clinical epi and epidemiological settings and anthropological settings, as well as the objects that it produced. So with that, I'd like to talk a little bit about my book project, because the book project was concurrent and spanned outward from those studies that I just mentioned on the slide. And in Addicted, Pregnant, Poor, I sought to answer the question, what forms of life are possible here? By engaging with all the social actors who are called upon to produce knowledge about addicted pregnancy, including women who use drugs during pregnancy, an anthropologist, myself, public health epidemiologists, advocates, social policymakers, treatment professionals, bureaucrats, and scientists. The pregnant women that I studied were made structurally vulnerable as a result of their housing instability, drug use, and poor mental health. Their lesser social status was determined by the dueling constraints of both addiction and pregnancy. Everyday lives were organized by patterns of consumption and insecurity, living chaotic, dangerous, and debt-filled lives in the daily rent hotels, and engaging in ongoing drug sex economy hustles to avoid homelessness, manage their addictions, and deaden their rage. Pregnant women were constantly displaced within and between privately owned daily rent hotels that charged between $35 and $60 a day to rent a single room. None of the rooms had bathrooms, and most looked like the one pictured here: dirty, broken furniture, chipped and peeling paint, bloodstains, and graffiti on the walls. The hotel owners made a tremendous amount of money from charging renters daily, accruing renter debt, and displacing renters prior to them establishing tenancy rights. I was able to identify and theorize how the pregnant women I studied operated in multiple time zones every day. She was on addict time, repeatedly searching for and satiating dependence on stimulants and opioids. Pregnancy time reminded her that her expanding womb was a ticking time bomb. On hotel time, the rent was always due. Treatment time demanded she answer, when was she going back? Was it too late? Could the baby be born, quote, clean if she stopped using today? These are questions she asked herself and also those that were being asked of her. Epidemiological time charted her previous experiences with trauma, violence, and risk into public health categorizations. Jail time reflected her repeated relationship with carceral regimes. Lifetime reminded her of her own history of childhood trauma, a life of substance use, homelessness, and institutional involvement. Working with addicted pregnant women in the daily rent hotels required the recognition of the ways in which they were emotionally, physically, and structurally bound in a limbo state betwixt and between these multiple temporal demands. And theorizing that multiple temporality has impacted the ways in which I apply for NIH grants as longitudinal cohort studies. Returning to the daily rent hotels, these patterns of consumption and insecurity among pregnant women produce stress and instability in a location that itself had become a contested terrain. The Mission District neighborhood in the city of San Francisco is experiencing unprecedented income inequality and has insufficient affordable housing stock. Rapid gentrification and increased policing in this neighborhood continue to this day to escalate already heated discussions about who belongs here and under what circumstances. Through extensive ethnographic engagement, I documented how local bureaucratic and clinical practices created a disability economy built around diagnosis and documentation of specific forms of mental illness, PTSD and bipolar disorder most commonly. This disability economy was designed to be responsive to the everyday trauma and mania experienced by urban poor women, while also seeking fiscal restraint in the allocation of healthcare between cities, states, and the federal government. Within the disability economy, a new social actor emerged that I called the neurocrat. It's a shorthand for neurological bureaucrat. Individuals recruited to document mental illnesses that enabled SSI disability claims, allowing for payments that could be used to establish some form of housing stability once drug and alcohol dependence was no longer recognized as a legitimate and eligible disabling diagnosis by the federal government. By visiting various sites of knowledge production, the epidemiologic, the clinical, the bureaucratic, the everyday, I was able to excavate the operations of biopolitics at work in this complex construction of comorbid addiction and mental illness. I traced the 1990s era US welfare reform policies and associated claims made by the public media about motherhood, drug use, and entitlements that still impact the management of pregnancy, addiction, mental health, mental illness, and families today. The nature and significance of comorbidity is deeply entangled in forms of care and governance that are produced in and between these epistemological sites, on the epidemiological survey, between a physician and her patient, on papers piling up in the neurocrat's inbox, and down the hallways of the Daily Rent Hotel. This is the vital politics at work at the site. Or as one of my interlocutors, Lexi, put it, when she told me about a neurocratic caseworker encouraging her toward a PTSD diagnosis after her daughter had died in the hospital prematurely. Lexi was forced off her methadone program because she was no longer eligible for the treatment funding stream due to her pregnancy loss. So because she was no longer pregnant, because her daughter died, she lost her access to methadone treatment. She needed money for housing. Lexi told me, the caseworker told me, quote, "You have PTSD, you haven't dealt with the death, you're in trauma and you can't work." But Lexi said to the caseworker, "No, because I've always worked. I came to this life late, to drug use late. I used to work. I didn't want to give up like that, but I had PTSD. You know I did. I mean, of course I did. But I just didn't want it to mean something for the welfare." So in addition to Addicted Pregnant Poor and its circulation, I'm very grateful for its circulation amongst outreach workers, parole officers, and other community members, as well as in the academic audience. I want to switch a little bit and talk about the impact and generative projects that have happened since then. So one of them is directly related to the multi-method research that I mentioned earlier. So we were able to look more closely to compare the Daily Rent hotels, which are privately owned, with publicly funded permanent supportive housing buildings, and look at the ways in which either of these built environments can exacerbate mental health risk environments or make trauma and substance use worse, and mental health symptoms worse for the women who lived in them. And so we were able to publish that in the International Journal of Drug Policy. That's all qualitative and ethnographic and includes policymaker data. But on the other side is the American Journal of Public Health article, which is the quantitative version of that same study, where we looked at levels of psychiatric comorbidity in a sample of HIV positive and HIV negative homeless women, and were able to characterize the types of violence and victimization that they were experiencing and associate that, or it was associated, we reported its association, with the housing type that they were living in. So this work was an example of a way to take deeply ethnographic and qualitative work and have it inform both quantitative and qualitative work. Second example I wanted to share is from collaborating with colleagues in the medical school at UCSF. So Andrea Jackson, Ashish Premkumar, and Laura Duncan were all OBGYNs. We took Lexi's case and we published it in the New England Journal of Medicine as a case study that's used for the second-year medical students at UCSF during the OBGYN rotations. So we're able to read that case and discuss it as a social medicine case and talk about how to change treatment practices. Work that's currently happening, that's more direct service clinical care oriented, is that I'm involved in a mixed method evaluation of Team Lily. Team Lily is the care team at San Francisco General Hospital that is running a wonderful program for pregnant people who have mental illness, substance use, and are experiencing homelessness to manage a healthy pregnancy, but they also concentrate on family unification and trying to be clinical advocates to keep the child protective services out of families' lives and keep families together. So we're working on an evaluation of that work. And I also work with a local residential treatment program called Jelani House, which is where most of the pregnant people whose infants are in the NICU post-birth. So they've already been separated by the state, and they go and stay in substance use treatment. And we've been able to do some trainings based on the book, working with their staff to talk about harm reduction and support for this group of folks. And secondly, or lastly, is to talk about the Academy for Perinatal Harm Reduction. This is a national organization of advocates that have created these wonderful documents that are facing toward providers, but also for pregnant people who use drugs, to understand what the evidence base is and to help get them care and supportive treatment. So just a few examples of the ways in which the work has continued to generate. And here's another. So I want to talk a little bit about my work with Dr. Margaret Kuchel, who's a key collaborator for me and a clinical epidemiologist and researcher at UCSF. So in working to sort of think about how to create NIH studies that are NIH fundable and community engaged, but also have a sociostructural analysis built in. So Margot and I were able to collaborate on 3 studies, one just funded. The first was a study of kinship and family-based housing. So it was really looking at families of older homeless adults who were experiencing homelessness and the ways in which they could or couldn't support their family members, and the ways in which systems got involved to create barriers for them. And that was an entirely ethnographic and qualitative R01 that we got funded, but it was nested within an epi cohort study that Margot's had called the Hope Home cohort, which is the longest running study of older homeless adults in the US, I think. I'm pretty sure about that. The next 2 are renewals of Hope Home, where we went in and talked more about caretaking, social isolation, and loneliness in this population. And then lastly, we've just been funded to look at the institutional causes for medical mistrust. So to try and understand ways institutions are functioning to make healthcare seem undesirable or unhealthy or unsafe for older homeless adults in Oakland, where this study takes place, and the role that discrimination plays in that. We've published quite a bit of qualitative papers on this study, focused on structural racism, intergenerational family poverty, so the structural vulnerability of broader family networks for families experiencing homelessness who have older adults, homeless participants as caregivers and their caregiving needs. So we found, interestingly, that many of the participants who were currently experiencing homelessness in our study were also acting as caregivers for other family members. And so we've been really trying to think about policy solutions and supports, but also, of course, in-home supportive services, or IHSS, you're not eligible for if you don't have an address. So we're also working on policy solutions to help figure out how to get supports for people who are constantly being displaced, particularly older homeless adults who have significant health conditions and geriatric conditions and advancement as a result of their homelessness, and intergenerational trauma. So that's sort of an NIH program. A more public-facing program that Dr. Sikkema mentioned is the Benioff Homelessness and Housing Initiative at UCSF. So this is a strategic science initiative that Dr. Kuchel runs, and I'm the director of qualitative research for. And the Benioff, BHHI, we call it for short, is entirely faced toward public policymakers and electeds. So it's strategic science in the sense that we really think about, we meet with and think about what are the policymakers, what are their questions about homelessness and solutions to homelessness, and then how do we interrogate the existing database. There's a lot of evidence that currently exists that doesn't get paid attention to, and then also think about additional studies that might need to be done. We work a lot with media and communications and thinking about health communications, both toward the public, but also particularly toward electeds and policymakers who work in that space. And just 4 projects that I'm sort of directly oversee that I wanted to highlight are, I was able to work with a group of medical students at UCSF to do a health impacts of street sweeps study, which looks at policing and displacement of unsheltered homeless individuals. We ran all the testing and COVID vaccine acceptability for homelessness in San Francisco and the East Bay during COVID. And so we were able to do some qualitative and ethnographic research on vaccine acceptability and able to publish that. Also did a study, so Mayor Schaaf, who's the mayor of Oakland, requested the BHHI to do a study because of the rising number of people living in their vehicles. So this is a really common issue with vehicular homelessness, vehicle residents who are unsheltered or sheltered in their vehicles, I suppose is a better way to put it. And so we did that as a response. We did a qualitative study of that and published that report and have done a lot of media around it as well. And then the California State Study of Homelessness comes directly from Governor Newsom's office. And it's a massive epidemiological and qualitative study of homelessness throughout the state. So we're in 8 different counties. We've done 3,000 interviews and 300 qualitative interviews, 3,000 epidemiological interviews and 300 qualitative interviews. We just finished up in our last county about a week ago. And there's 7 qualitative studies that I run. So one is focused on behavioral health, really looking at the intersection of mental health and substance use for people experiencing homelessness, precipitants of homelessness. So what are the missed opportunities? What led to this most recent event of homelessness and what could have been done? Barriers to rehousing. So once people are already experiencing homelessness, what are the barriers or what are the opportunities for getting folks rehoused? Experiences of Black Californians, experiences of Latinx Californians, so population-specific studies based on populations that are highly policed and racialized in California in relationship to homelessness, and a study on interpersonal violence. So that is some of the, and I just want to highlight all of these studies were done by students and postdocs. So these are all sort of in thinking about the mentorship and opportunities to support the work. BHHI has a robust postdoc program, and we have tons of postdocs and predoctoral and medical students and public health students working with us on the California State Study of Homelessness and other studies. So what about clinicians? And how do we bring the work of vital politics, looking at the intersection of mental health and addiction, to their doorstep? So I've collaborated nationally with a group forming and delivering a framework called structural competency, which really tries to look upstream. So take the social determinants of health and take it upstream one more level. So if we know from 5 generations of clinical and community epi that poverty and inequality produce poor health, what are the policies, systems, and social hierarchies that produce poverty and inequality? And structural competency is trying to get, in its sort of small and really modest lane, is trying to get health professionals who don't often have that orientation to think about that. And so we've been able to expand that work, done some research on it, evaluative research on its impact for students and resident trainees, brought it to UCSF. It's now a core competency in the UCSF undergraduate medical school. And so it shows up in different places. And global health education with some collaborators, and recently did a training at NIMH with the NIMH staff on structural competency and its impact on mental health research. The structural competency has been, I think, impactful in its own way, but it's limited, right? It's within medical education, which is incredibly conservative. It's within medicine, which is a field of study that produces its own structural harm. And so with that knowledge and that caveat, we've also developed the Repair Project in my department, which is in the Department of Humanities and Social Sciences. And this is a 3-year initiative that's focused on addressing anti-Black racism in science and medicine. So not just in clinical medicine, but also in the basic sciences. And I serve on the steer committee and co-run the research work stream for Repair. And our website is there. We have tons of teach-ins and events that we've been doing for the past 2.5 years. And so please check it out. I just want to highlight a few things. We've had strategic annual themes that are able to draw more on the humanities, focused on medical reparations, medical abolitionism, and this year decolonizing in the health sciences, to really think a little bit more critically than we've been able to in the medical school. What would be but first of all, what's the role of history, which the medical school is still lagging behind on, but also what's the role of critical social science and social science theory to inform kind of what imagined care we could imagine. And we also collaborate with Skywatchers listed here, which is a community arts organization that's helped develop the Community Grand Rounds Forum, which is an alternative education forum that kind of turns the expertise of medicine on its head and offers stories of medical engagement and medical trauma to health professionals, and then creates spaces for reparative dialogue, but specifically focused on UCSF institutionally, which is really the focus of repair. So that's vital politics. I'm going to switch to chemical politics now of the US opioid crisis. And I think I'm doing good on time, so let's get. So chemical politics. So I'm going to talk about this in 3 ways. First, work I've done in reductions in opioid prescribing in the primary care safety net, so that specific care setting. Work that I've done expanding access to medications for opioid use disorder, and work that I've done around housing and overdose vulnerability. And as I mentioned, vital politics and chemical politics overlap. We could talk a little bit more about how I'm sort of theorizing those distinctions, but you'll see traces in some of the earlier work in this work now. So reductions in opioid prescribing. So I've had a series of R01 studies from NIDA that are all qualitative and ethnographic since 2013, sort of tracing the ways in which opioid prescribing has changed in primary care safety net. So following initial concerns about the role of prescription opioid overprescribing to patients, producing circulation of opioids in communities that could lead to what's referred to as opioid misuse, as well as overdose, unintentional overdose. And I have an incredible team that I work with on this work, and I just want to highlight them. Recognizing that, again, many of them are pre-doctoral and postdoctoral students that I've been able to conduct this work with and in collaboration. What do we do on these studies? So our methodology, as I mentioned, is ethnographic and qualitative. So we do home visits ethnographically, and we do clinic observations ethnographically. In the home visits, we go to participants' home and see how they're managing their pain, their opioid use disorder, how they're interacting with family around changes in their opioid prescribing, key concerns that they have around employment and education and disability, as I mentioned in the example with Lexi, their ability to work or not work in relationship to their pain condition. And we have a number of people who also don't have a home. And so we visit them in sites wherever they're living and talk about the impact. Of course, you can imagine with people with chronic non-cancer pain, the impact of homelessness and unsheltered homelessness specifically being incredibly impactful for function and mobility. In clinical settings, we work with the providers. So we interview providers and participants, and then we meet with them and see how they interact with each other. And that included during COVID, following that into the phones. So care became, telehealth became the way that this was managed during COVID. So we did a COVID telehealth sub-study during the project when everything went, and got to be able to chart the impact of isolation and lack of interaction with sort of brick and mortar safety net primary care. What's interesting about that is that one of the impacts of the reductions in opioid prescribing was increased visits. So they made it so that pain patients used to be able to get a script maybe for 30 days. They would have to come in much more frequently. So you can imagine with a low income population that has transportation barriers, to be able to have to go to the clinic for these constant touch points in order to legitimize a renewal of a prescription was a huge issue for them. When it went into telehealth, it actually became easier for many of the patients. Even though they were isolated, as we all were during COVID, the clinical burden decreased during that time. So that was a benefit. And finally, of course, I look at the local, state, and national context of opioid prescribing. So the ways in which opioid prescribing is being characterized as an object of concern, particularly by CDC, the CDC guidelines in 2016, and now the guidelines that just came out last week in 2022 are really framing what clinicians do in response to opioid prescribing in this setting. We published a bunch from this qualitative and ethnographic work, including theorizing opioid pharmacovigilance, which is some work that I did really tracing the clinical and social history of the changes in opioid prescribing and how it relates to physicians' training, but also examining the risks of opioid treatment and how they differ in patients and provider assessments, looking at the impact of urine toxicology testing, substance use treatment, linkage, and then polysubstance use, so opioid and cannabis co-use and opioid and benzodiazepine co-use, as well as looking at the primary care safety net itself as a structure of medicine that produces challenges and harm in the time pressure that the clinicians in that setting feel like they have to be able to manage opioids in that setting. And again, looking at these, I just want to highlight that 6 out of 8 of these were first authored by postdoc and trainees. So again, the study's been really generative to offer opportunities for folks to author, be trained and author qualitative ethnographic work. And where has it gone? So, I've been part of a UC group that, so all of the UCs that have medical schools got together and they had a couple of people from each school nominated to be part of this working group. And it was multidisciplinary. So it was people from pain medicine and people from addiction medicine, and then social scientists. I might have been the only one actually, but a social scientist studying this. And we got together to think about competencies for medical education and residency. And so we were able to publish those competencies in pain medicine. I also work at UCSF to try and, provide conversation at the medical school level and across the social sciences around what's addiction medicine's role in the opioid overdose crisis, and how can we, again, reimagine care and care settings to better serve people who have chronic lung cancer pain, but also other people who might be having opioid use disorder or interacting with opioids in some kind of way in clinical care. And then lastly, I'm part of a small working group that works nationally with the National Academy of Medicine. And we've been charged for the past 18 months or so to create a series of webinars on the social determinants of opioid use disorder, to offer those webinars. And now we're currently drafting policy statements as a deliverable that will focus on health systems change and payer and payee and prevention strategies for addressing the opioid overdose crisis from a social determinants framework. So mood stands for medications for opioid use disorders, for folks who aren't familiar, but maybe more familiar with methadone or buprenorphine. So those are common treatments. And these medicines have been really well researched. I did my first methadone study in 1996. So we know a lot about them. We know that they improve overall health. They reduce opioid use. They reduce transmission of HIV and hepatitis C, and they reduce overdose mortality by at least half. I want to sit with that for a second, by at least half. Then let's look at this statistic. In 2019, between 40 to 87% of people with opioid use disorder in the United States were not receiving mood. So the treatment gap here is tremendous. We have a ton of people with opioid use disorder in the United States. We have some effective treatments. I'm not suggesting that medicalization is the only route to support people with opioid use disorder, but these medications have a lot of evidence behind them, and the access issues are significant. So, people experiencing homelessness and people involved in the criminal legal system have low mood utilization, so some of the lowest groups. So during COVID-19, some really interesting things happened. One of them was that the federal government lifted bans on some of the regulatory delivery mechanisms for methadone. And importantly, methadone is the most highly regulated chemical in the United States. You have to go to a methadone clinic or an OTOP to get it. And you have to have mandatory counseling, and you have to go every day. In California, you have to go every day. In New York, I think it's 5 days a week because it's not open on weekends. And in order to earn take-home doses, or doses you can control yourself, medication that you get to take home and take every day by yourself without supervision, was really stringent. You had to be in treatment for a certain amount of time. You had to have, all these modes. So when they needed to depopulate clinics, to decongregate them because of COVID, the federal government allowed for take-home doses to be highly liberalized. So, and it was really up to clinics to figure out what that meant for their patient population. So we did a study of one clinic in San Francisco, a qualitative study, to look at what the impacts were. They did a couple of things. They increased take-home doses and they moved methadone outside. So they reinvigorated a methadone van model that had been used historically, but also had a lot of limitations on being able to use this delivery system, even though community members really like it. So that study led to a really fruitful collaboration. So I was part of an opioid and drug policy and COVID substance use national collaborative that started just meeting every couple of weeks during COVID to talk about these drug policy changes and have social scientists get together who are doing research and talk about what we were learning. And through that collaboration, came to realize that Ayanna Jordan, who was then at Yale, but is now at NYU, and Carmen Albusi Garcia at University of Puerto Rico, and I all had take-home studies that we were all doing together. So we decided to join forces and publish our data together. Ayana Jordan's group was looking at financial structure for methadone. Carmen Garcia's group was looking at post-release methadone continuation for people involved in the criminal legal system. And our focus became housing, because what we found in San Francisco was that the housing interventions to take people into shelter-in-place hotels enabled take-homes, because if you were homeless, you weren't able to get them before, and that increased treatment stabilization. So it was a really interesting impact of federal change in methadone care practice delivery with a California state decision on shelter-in-place support for people experiencing homelessness coming together to produce some positive results. And we also published all of our data in a separate qualitative paper, and all that work was led by Leslie Soon, who was a national clinical research scholar at UCSF. We also did an issue brief for California Healthcare Foundation, who funded us, so we were able to put some stuff out that was more policy focused. And whoops, skipped ahead. And real recently in October, we got together, this COVID group got together again, and we collaborated with another author in the American Journal of Public Health, the National Urban Survivors Union, which is a drug users union that's based in North Carolina, but has membership across the US, and a group of folks from Urban Survivors Union who were on methadone patients, got together, did their own research and policy recommendations, and they published that in the Methadone Manifesto. And so we got together with our group and them and just presented at the National Harm Reduction Conference in Puerto Rico on a methadone liberation panel. And since then, the National Coalition for the Liberation of Methadone has formed, and it's a really fun coalition that has Urban Survivors Union members, groups of us that have done the research I just mentioned, as well as addiction medicine providers and other folks who are working to kind of create policy and public facing and policy relevant work to try and imagine different care structures for methadone delivery, again, to address that treatment gap. That's incredibly significant. I also collaborate with Leslie Soon and Owain Nguyen, who are both docs. Owain Nguyen is an implementation research scientist and doc, hospitalist at UCSF, and Leslie Soon is an addiction medicine clinical research scholar, as I mentioned. And we have a project with Marlene Martin, who's also a hospitalist, to look at harm reduction service delivery in the hospital. So again, it's another example of how we can think about care differently. The methadone liberation work is really about pulling methadone out of clinical spaces into community pharmacies and into other settings that are less regulated and more community friendly. This is saying people get hospitalized who use substances a lot, and they have terrible experiences in the hospital for the most part. So what would it look like if we tried to integrate harm reduction into the addiction medicine care team and talk about safer drug use, offer supplies, and have conversations about substance use and substance use goals that are more humane. So that's an exciting small qualitative study that I'm involved in. So lastly, housing and overdose vulnerability. So as you can see from this slide, the number one, overdose is the number one cause of death among people experiencing homelessness in many counties in California and in San Francisco. And you'll notice that the highest percentage of homeless deaths is attributed to overdose in San Francisco. So this is a huge, huge issue, the relationship between housing stability, housing transitions, and homelessness and overdose. So I've got two projects focused on this. The first one we've completed, which was the SRO project, Peer Overdose Prevention. This is my team, again, involved in this. And this is a community collaboration. So this was an invitation from the Department of Public Health in San Francisco to conduct a qualitative evaluation of a pilot project that they implemented in 2 permanent supportive housing SROs. And the intervention went like this. They identified tenants who were already involved in overdose response, so already experts, already saving lives in their residents and communities. And then they supported them through monetary stipends and additional training for that work. And it's a model that is now being considered for all permanent supportive housing in San Francisco because it had a lot of really positive results. Some of the results were that we had naloxone saturation on every floor in the hotel, so it made it really easily accessible. Another result was it improved relationships between staff and hotel residents because they were sort of collectively all trained and working toward overdose response in the buildings. And another is that it gave autonomy to residents. So they were already being supported for the work that they were doing and offered a lot of legitimacy and self-esteem to the folks who were doing this work, but often go unrecognized and unsupported. So, and I've done some work, including a lengthy KQED interview discussing this work with the collaborators in permanent supportive housing that I work with. I have a brand new study that focuses on poly substance use patterns, overdose vulnerability, and housing status. So this just got funded by NIDA at NIH, and it's part of the HEAL initiative. It's a project that I work on with my multiple PI collaborator, Ryan McNeil at Yale. And I'm really pleased to say this is the first NIH study that R01 that I've been able to be funded, that the investigative team, including SPIs, are all anthropologists and ethnographers and sociologists. So we're really proud that we got this funding. It hasn't started yet, so we're not proud of what we've done because we're just beginning, but proud that it was a possibility. And it's an entirely ethnographic qualitative study focused on fentanyl and stimulant polysubstance use, and it's in New York and San Francisco. So we're going to be looking at comparisons between New York and San Francisco, all of the interventions that they have in place for opioid overdose response, as well as linkages to treatment for people who have fentanyl and stimulant co-use. We have a conceptual model that's probably no one can see because the slide's too small, but just to highlight it, looking at structural environmental determinants and the ways in which those affect both drug use patterns and vulnerability, with a special attention toward racialization and gender differences in the sample. So we have a pretty sophisticated sampling plan to assess for that. And again, it's longitudinal. Getting back to the temporalities issue, we really want to be able to engage over time and see how the participants in our study are engaging in the public discourse that's being created around their overdose vulnerability and their addiction, as well as understanding the larger political and policy context in each of the places we're working. And with that in mind, we have an enormous stakeholder engagement and dissemination process. So that includes hiring people with lived and living experience of polysubstance use, as well as creating an active board of folks that's informing our study, of course, in traditional CBPR community-based research orientation, but we also have, again, stakeholders as key participants. So sort of at all levels, it's a really integrated process. And we have some interesting dissemination ideas. Ryan McNeil, my collaborator, has worked with Crackdown Pod, which is, I highly recommend, journalistic and academic mashup of people who use drugs reporting on the drug war out of Vancouver. And we're interested in dissemination practices that follow that model. And lastly, all of this is coming together for a current book project that I have to follow up on addicted pregnant poor. In my own department, I've collaborated with Vincent Adams and also with Lachlan Jane at Stanford to create a conference on alter life. So alter life is a conceptualization from Michelle Murphy at University of Toronto that thinks about human chemical relations and the ways that we all live through and by and after the chemical, and the ways in which that's informed and research can be informed by an anti-racist, anti-colonial framework that engages it. So we put on a conference in February 2022, and we're doing it again in 2023 with a small group of folks working on clinical ethnography. And I just presented at AAA last week one chapter from the book on the chemical politics of withdrawal. I'm also planning, one of my other roles that I play at UCSF is I'm the director at UCSF of education, training, research, and community engagement for the Opioid Industry Document Archive, which is an archive we currently share with Johns Hopkins at UCSF. And so I'm planning on framing the book around interactions between industry archival material that I'm getting a lot of support on working on, and the ethnographic work that I've been doing for the past over a decade now on the chemical politics of the opioid overdose. So I'm going to wrap up and by saying I hope that this whirlwind tour of a lot of work that I've been involved with, that I've been able to at least highlight and address the ways in which this work is really humbling, not just because it's intense, and the suffering is extraordinary, but also because within my position as a researcher and as an ethnographer in the space, humility is just a natural orientation to deep listening and working in collaboration with communities to close the distance of our understanding and co-create knowledge together. I try to share a body of work theorizing the vital politics and chemical politics by applying methods of critical medical anthropology in an NIH research-funded program that's aiming to increase knowledge about homelessness and health, that I'm theoretically and pragmatically focused on decreasing structural stigma in research, clinical, and policy contexts, and that I'm joyously committed to training and mentoring a workforce. So, thank you very much.
So extensive. Thank you, Dr. Kelly, for everything that you just spoke about, for the range